Pradeep Pindyala, Professor of Anesthesiology. Today I am going to talk briefly about what is defibrillation and the differences between defibrillation and cardioversion. Friends, the basics when you are using defibrillation, it's used only for shockable cardiac arrest rhythms. What are they? Ventricular fibrillation and pulseless ventricular tachycardia. Hence, there would be no synchronization when defibrillation is being given as a shock. Obviously, sedation is not required as all the cardiac arrest patients are invariably unconscious, and the energy use is also much higher when compared to cardioversion. This is the basic difference between cardioversion and defibrillation. Well, the definitive treatment of ventricular fibrillation is definitely to perform electrical defibrillation. Definitive treatment of ventricular fibrillation is nothing but defibrillation. Defibrillation is highly effective in terminating ventricular fibrillation when performed as early as possible when the ventricular fibrillation is noticed or expected or thought of. When defibrillation is delayed, effectiveness is reduced by almost 10% of survival per minute. Hence, if you reach to a patient 10 minutes later and you give the defibrillation, the chances of revival or survival is almost zero. That's it. That's what I was trying to convey. Well, to perform synchronized cardioversion, the defibrillator is placed on one particular mode that is called synchronized mode. You have to press that mode. That causes the monitor to track R waves of the QRS complex. So we have to avoid R on T wave, and the monitor itself tracks R waves in the QRS complex. That is how it delivers. Only when R wave appears, not on T wave. A synchronizing marker will automatically appear on each QRS complex when synchronized cardioversion is selected. That indicates that synchronized feature is on. The appropriate energy level selected is normally much less compared to defibrillation. And you need to press that button of select for particular discharge. Normally it is much less. You have to select and the discharge or shock button is supposed to be pressed and held. Well, the defibrillator does not release the shock when cardioversion synchronized mode is on until when the appropriate time comes. The defibrillator does not release the shock immediately. Instead, it waits for the next R wave to appear and delivers the shock at the time of R wave. This allows the shock to be provided safely away from the T wave, thus avoiding R on T wave phenomenon. This has to be known very, very clearly in your minds, friends. That is very, very important. And synchronized cardioversion differs from defibrillation in two aspects. Firstly, as I had mentioned earlier, the amount of energy needed to convert the rhythm is usually much less compared to defibrillation, and the shock is delivered in a different part of the cardiac cycle. Unlike defibrillation, which is used in cardiac arrest patients, synchronized cardioversion is performed on patients that still are alive and they have a pulse, but they are hemodynamically unstable. These are the patients who are given synchronized cardioversion, who are alive but hemodynamically unstable. It is used to treat both hemodynamically unstable ventricular and supraventricular tachycardias. Okay, that is very, very important to know the basics of these two. Now, coming to the latest guidelines by the American Heart Association for advanced cardiac life support. Well, 1 milligram of epinephrine or adrenaline should be administered intravenously every 3 to 5 minutes during the resuscitation after the first unsuccessful defibrillation. Okay, now high quality CPR is immediately resumed after the second shock for 2 minutes. And if ventricular fibrillation or pulselessness of ventricular tachycardia, that means pulseless ventricular tachycardia persists even after the next, on detection, at the next pulse or rhythm check, the advanced cardiac life support guidelines say you must give 300 milligram of amidaron to be administered as a bolus, okay, intravenously during the resuscitation. In addition, you may have to repeat with 150 milligram of amidaron may be given in additional if 300 milligram is not working, and later you can continue it, or there is another option, 1 milligram to 1.5 milligram per kg of lidocaine may also be administered if amidaron is not available. The latest American Heart Association guideline states epinephrine and amidaron are much more preferred over lidocaine. Thanks for patient listening, and I'm sure you have understood what I'm trying to convey regarding the basic differences between cardioversion and defibrillation. Thanks for patient listening. Have a wonderful day. Until next time, take care. Bye-bye.